this section, we'll be discussing lipid transport. In order to understand lipid transport, we first need to understand lipid digestion. Lipid digestion takes place in three locations. It begins in the mouth, where salivary lipase produced by the salivary gland cleaves triglycerides to diacylglycerol and free fatty acids. Dietary lipids are insoluble in water, so when they reach the distal small intestine, they have to be emulsified by bile acids. And the emulsification process allows them to become more soluble and also allows the digestive enzymes to have access to them to break them down. So then in the jejunum and in the ileum, the lipids are hydrolyzed by pancreatic lipase, phospholipase A, and cholesterol esterase, among other things. The digestive lipids then are absorbed into the epithelial cells of the small intestine. The short and medium chain fatty acids, things that are less than 12 carbons, pass directly into the epithelial cells and into the portal blood. The longer chain free fatty acids are reincorporated into triglycerides in the epithelial cells, and the cholesterol is esterified back into cholesterol esters. These lipids are then packaged into specialized particles that we call chylomicrons and are transported through the lymph system into the thoracic duct into the circulation. Chylomicrons are one of the categories of specialized particles that we call lipoproteins. Lipoproteins are spherical particles consisting of phospholipids and cholesterol on the surface membrane and a core of triglycerides and cholesterol esters. In addition to that, there are apoproteins attached to these particles, which are unique to each of the lipoprotein classes, and they provide structure and also allow the lipoproteins to be recognized by specific receptors. The function of these lipoproteins is to transport lipids throughout the body. Here's a picture of what a lipoprotein might look like. Notice that on the surface you have phospholipids and cholesterol along with these apoproteins. The outside of this, the polar head groups face the aqueous medium, and the hydrophobic tails face the inside, where you have a hydrophobic core consisting of triglycerides and cholesterol esters predominantly. Now, lipoproteins are categorized by density, size, and by their contents. The chylomicrons are the largest. VLDL, very low density lipoprotein, is the next smallest. LDL is smaller still. LDL stands for low density lipoprotein. And the high density lipoprotein, or HDL, is the smallest of them all. Chylomicrons are the least dense in addition to being the largest. And the density is low because of the high content of triglycerides contained in chylomicrons. The next in the density is very low density lipoproteins, in which the triglyceride content is somewhat less and the cholesterol content is higher, and that makes them smaller and less dense. The low density lipoproteins, in contrast, contain mostly cholesterol with a lot less triglycerides, and so their density is considerably less. Finally, the high density lipoproteins contain almost all cholesterol, and so that makes them extremely dense. Now, the function of each of these is slightly different. As you'll see in this chart, the function of chylomicrons is to transport triglycerides and cholesterol esters to some extent from the intestine to the liver and to the peripheral tissues. The VLDL, the very low density lipoproteins, transport triglycerides and some cholesterol from the liver to the peripheral tissues. The low density lipoproteins are responsible for transporting primarily cholesterol. And the high density lipoproteins transport cholesterol as well, except they transport it from the peripheral tissues back to the liver. Now, each lipoprotein has a different set of apoproteins on its surface. The chylomicrons predominantly have apoprotein A, and ApoB48, which is the short form of ApoB, and ApoC. VLDL, on the other hand, has predominantly ApoB100, ApoC, and ApoE, and LDL just has B100. HDL is predominantly consists of apoprotein A. Now, we're going to consider the chylomicrons and VLDL together as we discuss their function, because their functions are very similar. Chylomicrons carry dietary lipid from the GI tract to the peripheral tissues and then to the liver. VLDL carries lipid from the liver, either coming from the portal circulation or synthesized in the liver, to the peripheral tissues and then back to the liver. Both chylomicrons and VLDL deliver triglycerides to peripheral tissues via lipoprotein lipase, which we discussed briefly before. Lipoprotein lipase is an enzyme that's attached to the capillary endothelium. it binds these lipoprotein particles and hydrolyzes the triglycerides that they contain to free fatty acids. Those free fatty acids then can be absorbed by the peripheral tissues and either reesterified to triglycerides for storage or oxidized for energy. Here's a picture of what that looks like. So here's the VLDL or chylomicron with attached LPL, lipoprotein lipase. It binds it, it cleaves the triglycerides into free fatty acids, and those free fatty acids are absorbed and reesterified, in this case, in an adipocyte. Now, LPL recognizes chylomicrons and VLDL by binding to a specific aprotein. It's a form of ApoC called ApoC2. And this is found both on the surface of chylomicrons and VLDL. It's not found on the surface when they're created, but it's added later, transferred from particles of HDL in the circulation. The maturation of these chylomicrons and VLDL is aided by high-density lipoprotein. High-density lipoprotein removes cholesterol and phospholipids from the lipoprotein surface. Now, there's an important function for this. Think about this as the triglycerides are being degraded and being transferred from the chylomicron and VLDL to the peripheral tissues. There's going to be a decrease in the volume of that particle, but there's no concomitant decrease in the surface area. And so the chylomicron or the VLDL particle will become misshapen in that process. Well, this is fixed by the association with HDL. There's an enzyme called lecithin cholesterol acyl transferase, or ACAT. This is present in plasma, and it's activated by ApoA1, which is present on HDL. What it does is it takes cholesterol from the surface of the chylomicron or VLDL, esterifies it, and transfers it back to the chylomicron or VLDL. So in essence, what you've done is you've solved the surface area to volume ratio problem by removing things from the surface and putting them in the center to decrease the surface area and increase the volume. And this is what keeps the particles nice and spherical, keeps them from being misshapen. The result of this process is what we call a chylomicron remnant in the case of chylomicrons, or an intermediate density lipoprotein, IDL, in the case of very low density lipoprotein, or VLDL. Now these are slightly denser because they contain less triglyceride and more cholesterol than did the chylomicrons or VLDL particles. The chylomicron remnants are cleared by receptor-mediated endocytosis in the liver. Some of the IDL is also cleared by the liver LDL receptors, which interact with ApoB100 and with ApoE. And then some of the IDL is converted to LDL by hepatic lipase, which removes more of the triglyceride and puts it into hepatocytes. And the particle loses the ApoE in the process. So this is schematized on this particular slide. The chylomicron remnant interacts with the receptors in the liver, and it's taken up. The VLDL remnant, which is IDL, is recognized by receptors in the liver and taken up, but some of it interacts with hepatic lipase, loses ApoE, and then circulates as LDL. Now, because the LDL doesn't have ApoE, it's cleared much more slowly by the liver, and it circulates for a longer period of time than IDL does. It circulates in the plasma and eventually is taken up by LDL receptors at a slower rate in the liver and the peripheral tissues. So its function is to deliver cholesterol to these tissues. Now, HDL has the following functions. HDL is a source of ApoC2 for the chylomicrons and VLDL, which allows them to interact with lipoprotein lipase. As we indicated a minute ago, it also assists in the maturation of chylomicrons and VLDL to chylomicron remnants and to IDL. And it's also responsible for reverse transport of free tissue and plasma cholesterol to the liver for degradation and secretion. And it's this function that's earned it the name good cholesterol, because it's responsible for scavenging harmful cholesterol from the tissues and transporting it back to the liver. HDL interacts with a receptor called SRB1 in the liver and in the steroidogenic tissues, and is cleared from the circulation. So all of these lipoprotein particles are absorbed by a process called receptor-mediated endocytosis. Basically what happens is that there's a receptor, say the LDL receptor, on the surface of a cell, and it interacts with the LDL receptor on the surface of a lipoprotein that binds, and then it's internalized into a lysosome where the cholesterol esters, the triglycerides, the phospholipids, and the proteins are broken down and reused. Now, a defect in this process is illustrated in the following clinical vignette. A 15-year-old boy with no known past medical history comes to the emergency department complaining of crushing chest pain which radiates down his left arm. He's tachycardic, he's diaphoretic, and he's in severe pain. You notice that he has xanthomas, which are collections of lipid over his ankles, knees, and elbows. An EKG shows ST elevations in the inferior leads, and his lab tests are significant for elevations of CK-MB and troponin. His total cholesterol is markedly elevated, greater than 1,000 milligrams per deciliter. So he's having a myocardial infarction. Now, it's unusual for a 15-year-old to have a myocardial infarction, but a clue is in that markedly elevated serum cholesterol. This patient has a disease called familial hypercholesterolemia, or FH. FH is caused by mutations in the LDL receptor, and the consequence of these mutations is that LDL is not effectively cleared from the circulation. Now, circulating LDL, the longer it circulates, the more it has a propensity to be oxidized. And once it's oxidized, it can't be cleared by LDL receptors at all. Instead, it's scavenged by subendothelial macrophages, which take the cholesterol up and produce atherogenesis, endothelial damage, and then this endothelial damage can eventually lead to the formation of clots. Here's a schematic for how that happens. The native LDL is oxidized. The oxidized LDL is taken up by these monocytes and macrophages to form foam cells, which are macrophages that are full of lipid that originated with LDL. This causes inflammation, causes endothelial injury, and damages the endothelium. Over time, you get the accumulation of lipid in an atherosclerotic plaque, and that plaque has a tendency to rupture and can lead to clots in the coronary arteries and other places in the body. Familial hypercholesterolemia is the most common Mendelian disorder with a heterozygote frequency of 1 in 500. Heterozygotes have a 2 to 3-fold elevation in plasma cholesterol and suffer severe atherosclerosis, often leading to myocardial infarctions in their 30s to 40s. Homozygotes, on the other hand, have a 5 to 6-fold elevation in plasma cholesterol and develop atherosclerosis at a much earlier age. They often have myocardial infarctions as early as childhood. Now, there's a lot of people that have hypercholesterolemia without having one of these genetic deficiencies. High plasma LDL levels can also develop in people who simply consume a high-fat diet. In these individuals, the plentiful cholesterol supply from their diet causes a downregulation in the LDL receptor, increasing the plasma LDL with the same consequences as those you see in the genetic disease. And that's illustrated here. So in the top panel, you have a normal person who has LDL, which is effectively cleared by LDL receptors. Then in familial hypercholesterolemia, you have no LDL receptors, and so the LDL continues to circulate and leads to the problems that are associated with atherosclerotic disease. In somebody who has a high-fat diet, the receptors are saturated and they're downregulated, and again, this allows the increased LDL to circulate for a longer period of time, leading to atherosclerosis and the accompanying problems. Now, treatment for hypercholesterolemia includes cholesterol binding resins like cholestyramine and cholestyramine. These are things that bind cholesterol and bind bile acids in the GI tract and prevent them from being absorbed. You can also take HMG-CoA reductase inhibitors or statins. Now, statins function by decreasing de novo synthesis of cholesterol. So, because there's no cholesterol synthesis in the cells have to upregulate their LDL receptors in order to draw more cholesterol in from the outside. This upregulation of the LDL receptors leads to a decrease in serum LDL. Now, the question is, though, that we need to think about is whether or not statins would work in a patient that has homozygous familial hypercholesterolemia. And the answer to that question is no, because remember, statins function by virtue of the ability to upregulate the LDL receptor. Somebody who has homozygous FH has no functional LDL receptors to upregulate. And so giving a statin to somebody with homozygous FH would not work. Rather, these individuals have to be treated with these cholesterol binding resins and other things in order to, and a very low-fat diet in order to prevent the consequences of the disease. This ends the section on lipid